Welcome to ACOG's Video History Project. We're very happy today that past President Dr. Kenneth Noller is here for us to interview. Ken, thank you very much for coming.
Good to see you, Ralph.
Appreciate your being available. What we'd like to do is let's go through a little of your past history. Where were you born and raised?
Well, I actually was born in Denver, but I was raised in Topeka, Kansas. Good Midwesterner.
Good Midwestern. When did you first think you'd become a physician?
Well, I took some of the courses in college, but I really didn't think about it much until my roommate came back and said, you know, I'm applying to medical school, and I thought maybe I ought to do that. And so I did and got in, and glad I did.
Where was this college? What college?
Creighton University in Omaha.
So you stayed close to home.
Yeah, well, that was a long move for somebody from Topeka. It was 3 hours away.
When did you decide to go into an OBGYN residency?
Probably the first part of junior year. It always attracted me. Just something about the whole field. I loved obstetrics right from the start, from the first day on the rotation. So I did an obstetrics internship and then a residency.
And your residency was where?
At the Mayo Clinic.
And why did you choose the Mayo Clinic?
It's sort of the same story. A friend of mine applied and got in. He said, you ought to think about applying there. So I did. I hadn't really thought about it before that.
That certainly is a world-class institution.
It's a fantastic institution, and there are a lot of good institutions, but it really does a good job.
And then you finished your residency. Did you go on to any special training?
No, I stayed as a generalist OBGYN. I did do a Master's of Science with a focus in epidemiology and I was half-time research at Mayo for about 12 years.
And the other half-time?
Clinical, doing OB, GYN.
Now the Mayo Clinic has a very international patient population.
They do.
Did you notice any difference because of that type of population?
In obstetrics, most of the patients were local, of course, though there were exceptions. But gynecology, you certainly noticed it. A lot of patients from the Middle East, a lot of patients from Canada because it's very close.
In these patients, did you notice a different aspect of care? I mean, did they expect more or less?
In general, they were fine. We really didn't have a problem with expectations. I think they were all pretty happy with the care.
Well, I'm sure the care was the best that they could have gotten from most places. And where did you go after you left Mayo?
I went to the University of Massachusetts to become chair there and spent 10 years there as chair. That's in Worcester, Mass. Why
did you go there? That's a long way from where you...
It is. It's a long ways, and you know, a kid from Kansas maybe doesn't belong in Massachusetts, is what I'd always thought. But it was a good opportunity. It was a nice place, nice people, and I really enjoyed it.
Well, as you reflect today, and from your current position, you're very knowledgeable in that. We'll get into that later. But as you reflect on your training, who stands out as someone that may have had a really strong influence on you in your career?
George Malkasian, without a doubt. George, ACOG past president, was my mentor for most of the time I was at Mayo, the 17 years I spent there. And he was the one that really encouraged me to become involved with ACOG.
And what was your first involvement with ACOG?
I had done some speaking at various courses, but then the first appointment was to the GYN Practice Committee. That must have been, I forget what year it was, in the 80s sometime.
You also went on to be on other committees.
Oh yes, a lot of other committees.
How about local ACOG? When you moved to Massachusetts, did you get involved in local ACOG?
I certainly did, and there the person that was very helpful was Fred Frigoletto, another ACOG past president. In fact, I had been at UMass for 3 or 4 days. I could hardly find my office, and my secretary said, "There's a call from a Dr. Frigoletto." And Fred says, "I just wanted to welcome you to Massachusetts." And if anybody that knows Fred knows that's just typical of him. And I was involved then, from then on, with Massachusetts ACOG.
Now, you obviously become a president of ACOG. What made you want to seek the presidency?
It really was never a goal. I was more involved with the education part and the committee part, and I thoroughly enjoyed it. But I also wanted to get more involved with advocacy, and just one year I thought, gee, I'll put my name in, and if it happens, it does. If it doesn't, it won't be the end of the world. And fortunately, I was elected ACOG president.
Tell me about your presidency year. What was your major, shall I say, your major emphasis during that year?
Trying not to get lost, following you around at the various international meetings. That was the hardest thing. I think I really wanted to focus on the future of obstetrics and gynecology for the generalist obstetrician gynecologist. For many years, there had been such a focus on the subspecialists, and they were involved more and more in the academics, residency training, and I thought it was time that the generalists really took over more, had more involvement in ACOG and in actually residency training too.
Do you think that's happened?
I think it definitely has happened. For a while after the subspecialty started, virtually all the teachers in residency were subspecialists, and now most of the departments have realized that the way to keep patients is to have a big generalist division, and we have quite a few generalist chairs of OBGYN programs. I think it's, you probably know the number, I saw it recently, it's like 25% or 30% or something, which is a huge change from 20 years ago.
Now, during this period of time before you became president of ACOG, what's the most memorable experience that you had during that?
Oh, that's a hard one. Most memorable experience with ACOG?
No, just in the practice of the specialty.
Oh, practice of the specialty. Gosh, that's hard to say. I thoroughly enjoyed obstetrics. You know, it's every day having the honor of delivering babies was just amazing, and it's hard to pick out any one thing, Ralph. It really is. It was interesting when I was at Mayo. At that time, we delivered all our own babies, night or day, Monday through Friday. And it'd be like 20 below in January in Rochester, and you get that call at 2 a.m. and you'd have to get up and get out of your nice warm bed and get in your car, and you'd be kind of half awake. And by the time you got about halfway to the hospital, you remembered who the patient was and how nice she was, and you get excited about being there and delivering the baby, and the fact that it was 20 below didn't matter anymore.
Not many people practice in 20 below.
Not many want to.
That's very true. Although I don't think Mayo has any trouble recruiting.
They don't, no.
All right, now that you've been in ACOG, what's the thing you remember most about all the various aspects you've had in ACOG?
Again, that's a very hard question. I guess the thing that's most remarkable to me is that over the years, all of my best friends are people from ACOG and in ACOG, and people we meet at ACOG meetings, and we travel together. It's the friends I've made. That's the main thing. My wife and I have so much fun with our ACOG friends.
Now that you have left your former position in Massachusetts, what made you take a position with the American Board?
Well, after 10 years, I left UMass and went to Boston to be chair at Tufts and stayed there 10 years and was set to retire. I thought it was time to retire, and it just so happened that at the same time, Bill Drogemuller was retiring from the board, and so that position became open, and thought that might be fun, and I applied and was lucky enough to get it. And it's not clinical practice, but it's a lot of fun, and every day I look forward to going to work.
Do you do any clinical work now?
None whatsoever, no. Been retired from that for 5 years.
But you do have a major impact on clinical education.
We hope we do, yes.
No, I don't think. I don't think hope means anything. How have you found being purely in an administrative type of work compared to clinical practice?
Well, for the first probably 2 years, I missed it quite a bit. I really don't anymore, and I'm 70 years old now, and it was probably time to quit practice anyhow. And I love the administrative work, and as I said, I look forward to every day working.
Do you feel threatened by the the results of your work?
Not usually. We get an occasional nasty letter, but not too many.
I know that you get more than an occasional one, but that's all right. Let me go back. What would you say was the most memorable experience that you had in all of these until you retired from active clinical practice?
Probably the day that I became ACOG president was the most memorable, with my family there and having the opportunity to give a speech to the whole assembled group. That was a day that I'll never forget.
Right. Today, a young medical student comes up to you and says they're thinking about a career in OBGYN. How would you advise them?
I'd tell them that if they love taking care of women and believe in women's health, they absolutely should do it. And they are going to work hard. They have to love obstetrics, they have to love gynecology. If they don't, they shouldn't do it. But I would encourage them at any time to join the field.
What would you say is the most negative aspect of being an OBGYN?
The long hours. Though the way people practice now, it's much better. No groups really take call night or day anymore. They rotate, and they're laborious, and so I think it's easier to have a family and be part of and have a busy OBGYN practice.
We've seen, and you've seen, a major gender change in our specialists. What do you think that impact that will have on the future?
You know, it's hard to say. I think, as we all know, our female colleagues are put family first more than we ever did, probably. There are times we didn't spend as much time with our families as maybe we should have, and I think that's very appropriate. It's interesting, though, the men going into OB nowadays have the same feelings, and they want a family life, and I think that's absolutely appropriate, and that's the way it should be. And as far as the quality of care, I don't see any difference. Certainly the people we examine for the boards are just as bright or brighter than ever, and do a very fine job.
Now that you've been with the board for several years, what significant changes have you seen over the last 5 or 6 years in our specialty?
Well, we have more and more individuals who very early on focus in one small area of practice, and quite unfortunately, I believe we have too many people going into cosmetic gynecology and focusing in those areas rather than in taking good care of women.
One of the problems that specialty faces is the geographic distribution, especially in rural areas. How do you think we can correct that?
That's such a hard thing to do. Our residents train in academic centers. They're used to having all the specialists, subspecialists available in medicine and surgery and anesthesia and so forth. And to go into a rural community where you might not even have a blood bank is very hard. I think it's hard for them to do that. Plus, sometimes it's quite hard to make a decent living in small towns. I wish there was some secret way to do that. I don't have a solution.
Do you think that if we increase the number of OBGYNs trained, that we'd gradually see a movement out of the urban centers, or do you think that would make no difference?
It would have to be, I think, quite a substantial increase in trainees to make much of a difference. Of course, the problem is who's going to fund that. The federal government probably won't. I see some states, though, are starting to step in and consider doing some training, so paying for some training. So, but I think it would take quite a large increase before we can get to the small towns.
Now that you've been at the board for this period of time, what has been the changes that have taken place in the written exam in terms of emphasis on various aspects of the specialty?
The written exam really hasn't changed very much. I first became involved with the writing of questions some 20 years ago, and I don't see a whole lot of difference in the written exam. The oral exam, though, has evolved quite a lot.
Why do you think the written exam hasn't changed?
Mostly because the focus of that exam is basic knowledge in obstetrics, gynecology, a little bit of basic science, and you know, certainly the questions are updated as new material becomes available, but it's still mostly basic, everyday OBGYN.
What would you say right now if someone came to you as in a residency, they're in their second, third year, and they're deciding whether to take a fellowship or not? How would you recommend it to them?
Certainly the 4 fellowships that we recognize are all excellent career fields. The individual would have to be willing to give up something. If they wanted to go into GYN oncology, they'd have to give up obstetrics. If they want to focus on maternal fetal medicine, they'd largely give up surgery. And they have to know that and want that. If they want the whole broad spectrum of the specialty, then they shouldn't subspecialize.
There's a move afoot to create another subspecialty group called the Generalist OBGYN. What do you think of that?
I don't think that's a subspecialty group. That's the main group. And FACOG is doing a pretty good job with the academic OBGYNs. I think, my opinion is very soon we'll see a laborist subspecialty, or at least some recognition by ABMS, some sort of special certification.
Why do you say that?
More and more hospitals are using laborists, and I think there's a body of knowledge there that is important. I think they could learn from each other. Plus, many of the maternal fetal medicine subspecialists now spend very little time in the hospital. They spend more time doing consultations and high-level ultrasonography. And actually, if I were going into the field now, I might want to be a laborist.
That's one of the questions I was going to ask you. What is the much difference between a laborist and a maternal fetal medicine specialist?
The laborists deliver lots of babies. Maternal fetal medicine specialists, some of them never deliver any babies. That's not true of all of them, of course, but they tend to focus on just the high-risk cases. And laborists tend to take all comers, and especially those low risk. There are a lot of practices now that only do prenatal care, and so much like the pediatrics, especially most pediatricians don't have hospital privileges anymore, and that might happen in our specialty.
You think that's really a realistic thing to look at?
I think it might happen. It wouldn't happen overnight, but in the future it might.
How would that impact upon board certification?
It would have to evolve. It would definitely have to evolve.
Now, considering the members of the board, knowing most of them, how do you think the current board would look at that?
Very negatively.
I think the college would also look at it very negatively.
I would hope so. On the other hand, with the change in practice, we may have to adapt, or at least our successors may have to adapt.
Well, let me ask you another question. Since we've kind of hit upon this, where do you see the future of the specialty going?
I suspect, unfortunately, there are going to be fewer and fewer individuals who do the broad spectrum of obstetrics and gynecology. I think there'll be more individuals that focus on office practice, but there's hopefully going to remain a strong core of individuals that do obstetrics and gynecology. We recently, actually we're still in the midst of it, did a poll of individuals who were in their 6th year of the MOC process, and over 80% still describe themselves as general obstetrician gynecologists. I hope that lasts a long time.
Now, let's go back a little bit. If you see changes taking place where there's a large group of people get their board certification, but then stop doing anything in the hospital, let the laborers take over everything, kind of like internal medicine has done with their hospitalists, what do you see that will do to the future of our specialty?
It'll fragment it some. It will be different. It would be more like medicine and pediatrics eventually. I think it's going to take a long time because most of the individuals going into OBGYN still want to do the full specialty. It's hard to predict how it would change it, but it certainly would.
What would it do to the board exams, since it's now a limited certification?
Yeah, right now, of course, you can't have limited certification. When you take your oral exam, you have to be examined in all 3 areas. You have to have case lists in all 3 areas. That might have to change. We've changed for the subspecialists, the 4 official subspecialties, quite a while ago. They still are examined in all 3 areas, but their case lists, they can use residency case lists. But as more and more individuals stop going to the hospital, that could be a problem. Right now, you aren't eligible to take your oral exams if you only have an outpatient practice.
You see that changing any time in the future?
Not in the near future, no.
That's really not the full range of the specialty.
No, it isn't. Not at all.
All right, one last thing. What else would you like to add to this interview regarding our specialty?
I just hope that medical students realize what a need there is for specialists in women's health care. We are really the only specialty that cares very much about women's health. We're devoted to it, and I hope we can keep that flame alive in enough medical students that the specialty continues to be solid and grows. There's lots of specialties and subspecialties that take care of old men, but we're the only one that really takes care of women throughout their whole lifetime.
There's been a lot of talk about changing residency training programs to try to adapt to some of these changes by, for example, if you're going into general OBGYN, you take the full 3 years, but if you're going into say oncology, you only take 2 years and then move on into your fellowship.
Well,
Do
right
you think that's a
now,
reality?
right. Well, actually, for more than 10 years, if you have a position in one of the 4 fellowships, you can take your first year of subspecialty training as your 4th year of residency. And about 3 years ago, we changed the requirements a little bit, where you can do your 3rd year as a senior resident and your 4th year if you wanted to focus on one aspect of gynecology. You wanted to do more surgery or more MIS, you could do that. The problem is that the program directors need residents to cover their services, so none of them will do this, but it's been an option that's been available for several years.
So the service becomes more important sometimes
In the education.
Those of us that have been program directors are well aware of that.
Oh, yes, yes.
Is there anything else you'd like to add?
No, Ralph, it's been a pleasure talking with you.
Well, thank you very much. I appreciate you. I can tell you, you were one of my favorite presidents. We had a lot of fun.
A lot of fun together.
We got to do go to a lot of interesting places.
You and Jane and Mary and I,
Yep.
we did.
And hopefully we'll continue in the future with other things.
That's great.
Thank you very much.
Thank you, Ralph.